motivating the medical staff. I'm not really here to advocate for a good pay rise for the medical personnel, but the reality is today that when these professionals are underpaid or are less remunerated, they tend to prefer or prioritize treatment or handling other cases that might bring them income. We need to look seriously into this, Honorable Speaker. On the socio-economic front, it would be necessary to have a deliberate program for addressing the particular needs of the thousands of women and girls already affected by fistula, or those that have undergone successful fistula repair. Currently, we have great programs, poverty alleviation programs, for example, which have had successes in attempting to reduce the levels of poverty in our country. But most of these programs, such as SACCOs, they are still excluding women who are living with fistula, simply because these women are hidden, they are isolated, they are not seen. Besides, most of these poverty reduction programs tend to benefit the active poor. And honestly speaking, as you've seen from these women, they are active, they are poor, but they are more vulnerable, which is why these programs cannot reach them. So they need a deliberate approach to help them come out of poverty. I will not cite many examples, but for all of us who are here, especially in the education sector, many of these ladies you've just seen here, got fistula when they are still under 18 years. Some of them were in school, but even our education system rejects them. They cannot fit, even after treatment, and they want to go back to school. These are things that we all need to reflect about if we are talking about eliminating or ending fistula in this country. At the family level, and after undergoing successful surgery, these women remain vulnerable, marginalized, and are often abused. The present laws are not relevant to them without very specific approaches to make them benefit. The Association for Rehabilitation and Reorientation of Women for Development is a grassroots-based NGO taking on the holistic care of fistula. We at Terwode feel that quality treatment of fistula incorporates reintegration. We have reintegrated several women in the Teso sub-region, but the need at the national level is so huge that we are unable to do it single-handedly, which is why we need all your support. Terowode has an innovative approach which has proven cost-effective. It uses a diverse community-based volunteer workforce at various levels to identify patients, refer, and also wait for these patients after treatment, take them back home into their families, and reintegrate them into society successfully. Initially, investing in such an approach appears expensive, but it is proven very successful in the Teso sub-region where we are coming from. And we now call for your support to help us reach out to many of these women who need these services countrywide. We are available, our chief guest. We have the capacity, we have the skills, we have the innovations, and we are very ready to work with all of us who are here to make sure all these services benefit all the women who are out there. I thank you all for coming today. Like our MC has just said, it's a fundraising exercise. So give us your support.
Thank you very much, Alice, for that. But I'm happy to inform you, Alice, that if there was no one listening, at least I am sure the Right Honorable Speaker listened. And with her, it's not an issue of sending, it's an issue of being there yourself. She will handle the issue in the best way she knows how. We've seen it before, she won't disappoint on this one. Thank you very much, Alice.
The UNFPA country representative, the CEOs of corporate bodies, the executive director, Terewode, women and girls who have survived fistula, all partners, ladies and gentlemen. It's an honor and great pleasure for me to be a part of this function. I wish therefore to take this opportunity to bring you greetings from the Fistula Care project that is managed by Gender Health with support from USAID. This function is seen as very important to all partners that support the government through the Ministry of Health and all other ministries to address an important aspect of maternal health. The theme for today, obstetric fistula, addressing the challenges, is relevant. It is indeed a reminder of the fact that for every woman who dies, 6 to 15 survive with chronic and debilitating ill health, including obstetric fistula. We do recognize the substantial investment that the Ministry of Health and all her partners have made in improving maternal, newborn, and child health. Fistula care has certainly become a priority to the Ministry of Health, and efforts are realizing a reduction in the prevalence of fistula to the national rate of 2% from 2.5% in 2006, of course with variations across regions. Uganda, having been selected to host the recent international conference on obstetric fistula in collaboration with the Gender Health, is testimony to the strides the country has made in improving fistula care service delivery through innovative approaches undertaken in the area of fistula prevention, treatment, and reintegration. The National Fistula Technical Working Group, at which Gender Health, Terewode, and many other partners sit, has continued to provide technical guidance to fistula collaborations and partnerships. Incorporation of partners with technical and comparative advantage in fistula prevention, treatment and repair, as well as social integration, is steadily increasing access to fistula care and ensuring quality of care for women with fistula. Despite these efforts, obstetric fistula remains an ordeal to women suffering from it. The plight and double trauma that women with fistula experience, as in most cases they do lose their babies and yet go away unable to control urine, stool, or even both, does require concerted efforts. With the current fistula prevalence of 2% of women of reproductive age, a backlog of women that have fistula ranging between 140 to 200,000, and about 1,900 women getting fistula every year, we believe the burden of fistula is still big in Uganda. While any woman in obstructed labor can get fistula, if emergency cesarean section is not provided timely, there are regional variations, with those currently most affected being Western region, or commonly called Bunyoro region, which is atop with 4%, followed by Northern region at 2.3%, Central region at 2.1%, West Nile at 2%, and Madam Speaker, the East, Near East, commonly called Busoga area, follows. Is amongst the top 5 regions with the highest prevalence of fistula in the country. It is ironical that this is the area where you and I hail from. To be able to change the trend of fistula in such regions, strong public-private partnerships are paramount. Key aspects to address would notably include supporting activities that are geared towards increasing knowledge and awareness about fistula in our communities. And these should really target the 38% of women that we currently know who have fistula but for various reasons do not come out to seek for treatment. Many don't know that fistula can actually be repaired. A number may know, but they don't even know where to seek for the services from, while many just feel embarrassed to come out and, mention they have fistula, and indeed a number think it is expensive. So we see efforts that should be geared towards 38% to see that all these women come out to seek for the services. Partnerships are urged to address sensitization of women in communities on the importance of attending antenatal care at least 4 times and delivering from health facilities under the care of trained health workers, so that in the event of obstructed labor which is causing fistula, then health workers will be available to provide immediate emergency obstetric care and avert fistula. And indeed, efforts should be geared towards the 43% who currently deliver from home in the country. We need to support improving access to fistula services, and this requires supporting training, mentoring, and coaching of critical staff, those being the midwives and fistula surgeons. Support to fistula camps and provision of required medical equipment and supplies is essential. It's important to as well support social reintegration of women back to their communities after repair, including those deemed to have incurable fistula that is coming up of late. We know that women who live long with fistula are usually seen with broken families and social networks. Advocacy, Madam Speaker, for adequate resources to sexual reproductive health, including fistula, remains a key aspect of addressing fistula at various levels. I wish to commend Teleode for the partnership with the Gender Health Fistula Care Project that has brought a smile to many women's faces, and to appreciate all efforts geared towards increasing awareness about fistula, prevention, treatment and repair, as well as social reintegration. We know for sure that each and every one of us here can play a critical role in one way or another to free women from fistula. I therefore look forward to strong and sustainable partnerships that will ensure fistula-free generation in Uganda. I thank you all.
I don't want to go into statistics, but you know how big the Commonwealth is. And you can imagine if one Commonwealth country like Uganda has 367 MPs, more than a third of those being women. If you multiply that by over 50, how many women are under her stewardship? She is not an ordinary person. She is an embodiment of the achievement that we all can get if only we stamp out a little bottlenecks in our lives, including and not limited to fistula.
Okay, thank you very much. I'm Esperance Fundiram, the new UNFPA representative. I'm very glad to be here this night, and I would like to thank the Honorable Speaker, Right Honorable Rebecca Kadaga, for her commitment to maternal health and to the reproductive health and rights of women and girls in this country. Last week, I saw her with the Association of Gynecologists, and I think we are starting a journey to change the situation of reproductive health and rights of girls and women in Uganda. The Speaker of Parliament, the Right Honorable Rebecca Kadaga, the Minister of Health, the members of Parliament present here, the Country Manager of Engender Health, the Executive Director of Terowode, and all the participants, good evening. I think a lot has been said. We know about the statistics. We have seen the survivors of fistula. So I think by now everyone understands what fistula is. I have been asked to talk a little bit about the barriers towards eliminating obstetric fistula in Uganda. Our guest of honor, the main barriers to eliminate obstetric fistula in Uganda are related to limited access, availability, accessibility, and affordability of services for prevention of fistula, such as family planning, which helps one to have planned pregnancies and reduce early pregnancy. Antenatal care to identify high-risk pregnancies prone to fistula, and quality delivery care that monitors risks and institutes timely action to avoid cases of obstetric fistula. Preventing or delaying pregnancy until one is ready would be the first intervention to prevent or eliminate obstetric fistula in Uganda. But we know that use of family planning services remain low at 30%, with unmet needs at 34%. The 24% teenage pregnancy and the fact that more than 50% of all pregnancies are unplanned point to large unmet needs. Therefore, our bold action would be to stem out teenage pregnancies and associated early and forced marriages. We have also to address the health system factors that affect the accessibility of health services. Another barrier to eliminate obstetric fistula relates to limited access availability of quality services, antenatal and delivery care services that should identify and manage high-risk pregnancies. To eliminate fistula, we must also ensure that there are adequate services for repair for all new cases as they occur, as well as a mechanism to address the 200,000 backlog. When I hear this figure, I just can't comprehend. We need to do something different, outside the box. We have seen a few number of the survivors
if we have another 100,000 or 140,000 hidden in villages, I think we need to do something, and not only the officials, but also everyone in communities, to really make sure that those who are already affected can be treated. It can be treated, so it means that we don't have to lose almost close to 250,000 of citizens to this condition. The routine fistula repair services are in 13 national teaching and regional referral hospitals and a few private not-for-profit faith-based facilities. Most of these facilities are urban, based in contrast to where most fistula cases are located in rural areas. We've already heard that every year we have 1,900 new cases. I think it is unacceptable. Probably the weakest and least addressed area in eliminating obstetric fistula is the gap in provision of fistula reintegration services, the subject of the fundraising dinner today. At this point, Honorable Speaker, allow me to acknowledge the work of Terwode that has pioneered fistula reintegration services in this country. The people who work with fistula are really like missionaries, because they're dealing with a population that is usually poor, in rural area, no income. So it means really they have to be congratulated for this service that they are rendering to the nation. I've been advised not to talk about what we have done, but we have partnered with everyone in the area of fistula to really make some interventions that are considered now as best practices. As I talk, we have somebody from South Africa who has come to document the experience of Uganda. So I think we have also the Mulago National Referral and Technical Hospital that has been accredited by the International Federation of Gynecologists and Obstetricians as a global center for advanced fistula repair and training. I think this is commendable. Our intention is to continue supporting Mulago, but also build capacity of Mbarara and Gulu University teaching hospitals to reach same accreditation standards. I think as UNFPA, what we can pledge is to work with the Ministry of Health and Parliament first to design and implement an aggressive program to improve maternal health. Because in the first place, fistula is a failure of maternal health. So we need to focus on improving maternal health while we are also providing the services to the people who have been affected by fistula. Prevention first, and of course continue to treat and also to reintegrate. To Terwode, I think we need to engage to see how we can explore ways of working together to support in rolling out a program for fistula reintegration. That's what I can promise today, because we need to discuss and see how we can really reach out to the areas where it's mostly needed. But as I would really would like to stress that we need to do something unique outside the box to improve the situation of maternal health, because fistula is a consequence of non-functioning maternal health services. So the guest of honor, the Executive Director of Terode and the Executive Director of Gender Health. I think we are going to work together. And I commit the organization that I represent, the United Nations Population Fund, to walk this journey with you and to make Fistula history in this country. Thank you.
It's actually bigger and better. We do appreciate it. Thank you very much.